So I'd like to thank all of our presenters today, and especially on this panel, for enlightening presentations. And I think the three presentations in this panel have all done an excellent job of synthesizing the how of business engagement in population health, specifically looking at the pros and cons, barriers, obstacles, but then also really what is the role and what are the specifics of the how in terms of laid out here, but also in some of the other examples. And John, you actually answered, and before people come up for questions, I'll throw out one question, but folks, please feel free to approach the mic with questions. But you actually answered my first question, which I was going to ask how organizations and businesses maintained and ensured organizational alignment in multi-stakeholder coalitions. And I think you answered that pretty succinctly with your example of the Pueblo multi-stakeholder coalition, and that there needs to be strong mission, goals, vision statements that are instituted up front. But a second question for any of you or all of you really relates to long-term sustained engagement of multi-stakeholder coalitions. And from my end and my interest, I would like to know your thoughts on how to, and from a very general perspective, how to build in programmatic components or structural elements that ensure that these multi-stakeholder coalitions that organizations and employers can play a part of, how do you ensure that those are sustained over a longer period of time than just a 1 to 2 year window? And then also, how do you, or can you ensure that those multi-stakeholder coalitions survive past initial seed funding?
So this is what keeps me up at night. We started our coalition, as I said, a little over 2 years ago. And, my biggest dilemma is, how do I continue to demonstrate value? So I think one of the big things is any coalition to be effective, even though every voice has to be heard, there has to be some strong leadership and someone ultimately who's keeping that coalition together and moving forward and communicating clearly. But then the other issue I think is, have we made progress towards that reason, as John said, that we got together in the first place? Are we starting to see what are the measurable objectives out of the gate? I think when you start a coalition and you define what are we working on, you should have some short-term and longer-term milestones and be able to say, how have we done towards meeting those? And sometimes those milestones will change, but let's collectively say, the milestones need to change, and here's why. And let's be able to demonstrate that we are making progress, and maybe sometimes we've been delayed or haven't gotten as far as we had hoped, but here's what we have accomplished. And so every year, I put out for my members, here's a list of what we've accomplished this year, and here's what we still need to do. And that's a lifetime's work.
Well, my thought is, well, of course, I agree with this. I think that working on this upfront business with the why is really important as you build these coalitions. I think people have to have a clear understanding. I think they have to recognize right up front that this is a long-term issue. This is not a 1 to 2 years. And then lastly, I'd say, though, practically, and you're doing this, you got to work like crazy to get results. You've got to have results. You've got to get them in 6 months to a year. I'm not talking some giant change, but at Pueblo, for instance, I'll pick on them for a moment. They're working on teenage pregnancy. That's one of the things. Working on obesity, and the third thing. And I know they've had results already on teenage pregnancy in that community, decreasing it. And so you've got to work really hard to make sure you have results, because those results then continue to help keep the people in the game. If you don't have them, you're going to struggle. So people are only going to stay with you for so long unless you generate some level of results.
So I can speak to the example in Minneapolis, St. Paul of the Institute for Clinical Systems Improvement, which is a healthcare quality improvement collaborative, not exactly a health more broadly RIT collaborative, although it's working on those issues, thinking about those issues. And the key was certainly leadership and formation, demonstrating early results, becoming embedded in the fabric of the culture of the community in terms of how it became and is now embedded in a very positive image of what it provides to healthcare providers in this case. and thinking through how it evolves through several iterations. So it's been going for 24 years, and it's had several major resets based upon things that have occurred. And then what are the threats to it? The change in leadership over time in the major sponsoring institutions has been a threat to it. People who come into the community in corporate leadership roles, in this case insurer leadership roles, that are part of the community and committed to it locally and understand it as distinct from other healthcare communities, that has been a threat. I think the other, and I forgot to mention this, skin in the game kind of criteria was the fact that all of the stakeholders have calculated the economic value, put in real value in terms of either in-kind or financial contributions, and that's been sustained over a long period of time for the results that have been gained. So that the threats, again, change in leadership, and then actually change in executive leadership of the coalition have been. We have had some transitions there that haven't always been the best. So those are some of the things. You need to continually make sure that it's relevant and energizing and valued by the folks that are participating.
But do we have a question from Charles?
Yes, thank you. It's fascinating. I just want to, that's one thing, and that is just ask a question about, you see triple aim framework, and I know Don some, and certainly Don Berwick came up with this years ago. I think triple aim is part of the businesses engaged, but I think to keep engaged, just asked a question about, again, productivity. I've seen it some place, the Department of Defense calls that the quadruple aim. So you have the triple aim plus, others say triple aim plus productivity. But the whole idea is one of the outcomes looking at disability, which is obviously before in terms of health, it's one of the morbidity issues, and also reduces healthy life expectancy, which we heard earlier about blue zones. How does, I think, keeping businesses engaged also, because they want to have high-performing employees, but also I think the communities in general want to have people who are very, have productive in their own way and purposeful and so forth. So, in terms of business coalitions, is productivity coming up in the conversation, not simply healthcare or health per se?
So, my background is in outcomes research, so I'm a big fan of productivity measurement, and I'm hoping that sometime soon I will get some of my coalition members to start to measure lost productivity in a systematic way so that we can look at that data. Because, what I'm trying to convince them of is, this is HR benefits people, they're trying to justify an operational budget, and they're using direct medical spending to do that. And we're saying, look, there's lots of research out there that shows the indirect cost is even greater for many diseases. And you need to be able to quantify that in order to justify these programs. And, we have people like Kathy Bassi who's done this stuff and been expert with it, and people at ACOM doing it. So I'd like to get the employers to start to measure lost productivity. But what I'm finding is it doesn't resonate with the benefits people. They're not convinced that it's a meaningful measure. They're not convinced that those measures aren't biased in some way. It's self-reported in most cases. And I say, look, if anything, it's going to be underestimating the total productivity loss, because nobody's going to say, I sat on my ass all week when they didn't. Okay, so if anything, it's an underestimate. But it's a real hard sell. Now, one angle we're starting to work is we've spoken to a group called the CFO Alliance, national organization, but that started in Philly. And they've done research with the CFOs where the CFOs say health and productivity is our number one concern. But that message somehow is not connecting with the benefits and HR people who think the CFO is only interested in direct medical cost. So we're going to be thinking about how do you get that message out or get a meeting of minds.
Our experience has been discussion but no action on that one.
So Nico Pronk, I think, from our organization is better equipped to answer that question, but certainly productivity is an important concern, I think, that we'd like to be able to use better. And certainly I used it in my chart in terms of making the business argument for why business should be engaged in this to begin with as part of it. So we probably need better measures for and accurate measures for how to address it. Yeah, I'll try using the measures, right. But the data is hard to bring together, as I understand it, because it comes from different sources. So with apologies to if I'm not touching all the appropriate bases, Nico. But then you also mentioned the quadruple aim, which I think is a separate topic. The quadruple aim, as far as I understand the military used it, and how I've been impressed that they used it in this conversation I mentioned in San Diego, was the Admiral was pretty clear that the healthcare department or function of the Navy was in service of the larger mission of the military. And what we don't have, the way I try to translate this to a civilian sort of system, we don't really have that same concept that American healthcare is in service of larger society. I mean, and the triple aim doesn't help us with that as far as it goes. I mean, it does indirectly. And so I've been turning over in my mind is exactly how that concept could be further articulated or thought through in such a way that there's a civilian equivalent of the fact that, and it's captured in Kathy, your diagram, in terms of the fact that healthcare erodes, as your diagram showed, these other determinants of health. And the absence of such a broader notion that has sort of the salience of the current triple aim allows healthcare to be narcissistic, and for us to be narcissistic about health as the only objective. And we run into that when we talk about health in all policies at this roundtable, when it's not just health in all policies, it's education, it's the other determinants of health. And we don't have a concept on how we should talk about that. So I think, although you conflated both of those sorts of issues with your question, I think it's important for us to sort of think about that and ask ourselves whether that sort of notion would rise to the importance of actually becoming a fourth aim or not, as the military has done. So I think that's worth some additional.
Hi, I'm Sally George. I'm a program officer at the Robert Wood Johnson Foundation. And Neil, I was pretty struck by your comments about your learning collaborative of your folks in your coalition. And I'm assuming now from your previous comment that they're mostly HR and benefits folks, which surprises me because you said that mostly they're national organizations, right, that are just this happen to be based in Philly. So you would think that they'd have corporate medical directors, right?
It's a mix.
It's a mix.
It's a mix, but the people we have are mostly benefits.
Interesting.
Benefits directors.
Okay. Because we're working with the Vitality Institute and then also IBM to think about developing a corporate health leadership program for folks like from small and medium-sized companies who'd be more of those HR benefits, wellness coordinator kind of people, or for larger companies that'd be more the corporate medical directors. And we're thinking about, trying to get them more up to speed on population health and thinking more about social determinants of health and really creating a cadre of leaders within the business sector who can, sort of lead this whole population health movement within the corporate sector. And I would just love to hear, sort of your thoughts about how these folks learn, how you think they might be, if you think they might be receptive to this, if you think this is needed, or if you think we're like way off in left field somewhere and we should scrap the idea and try something else.
I think every company and its structure is a little bit different, and some of it relates to size and resources, some of it relates to culture and organizational structure and all sorts of other things. So almost all of our members have a wellness program of some sort, as was said this morning. That could mean a lot of different things. Some of them have a full-time wellness director. Some of them totally outsource it. Some of them have a corporate medical director who's involved in overseeing it. In a lot of these large companies, the corporate medical director is really more that traditional occupational environmental medicine person, safety person who doesn't get involved in benefits decision making. So it's really very variable. And one of the things for me as a fairly new coalition director has been learning what are the leverage points within my companies, and can I even get the benefits director to introduce us or to bring to the table some of those other people so we can have that kind of conversation.
So the purpose of the company, the purpose of the corporation, and its strategy, its fundamental strategy, is the province of the CEO and the board. And if we're not reaching for the CEO and the board, we can't expect to have an argument that's based upon the fact that business's value proposition includes working with others in terms of improving community health without reaching to that level, in my opinion. I'd be interested in others' opinion on this. The second point I would make is that the various functions within a company, like the benefits managers, corporate medical directors, if they exist in companies, and so forth and so on, already begin to have a particular interest in that value proposition that I laid out. So that if you looked at the last slide that I had with that had the sort of the levels of effort, the corporate HR managers are going to be interested mostly in purchasing healthcare and about the policies for the workforce. But they, as I think you said, may not be engaged in terms of the community benefit or the community outreach or so forth. I think you made that point very, very well. I think there are a lot of other examples within the company. So I think from our point of view as a roundtable and thinking about how to approach and engage business, we need to reach high, and we need to reach right into the central reason for business. I would argue that we need to reach right into the business schools and affect the thinking of people as they train, in addition to how they begin, the various functions within companies begin to execute that strategy, such as HR or so forth and so on. So I would make that argument in response to the question.
Yeah, and I would agree with you 100%. I think sort of the caveat there is until we get that generation or get that message more widely spread, there are some companies where we're getting a lot more done because the C-suite is not involved. And so it all depends on sort of the company and the culture and who's in what position. Yeah.
And this is obviously complicated by the fact that we have a lot of companies consolidating big scale across many geographies, and it's hard to get the attention of the CEO and the central folks because of that.
Please go ahead.
On this point, Ray Baxter from Kaiser Permanente and the Roundtable, I'd be interested if the panel could pursue this issue of culture and the type of company a bit more, because it seems to me that there are companies that are rooted in place that have a workforce that they are investing in and intend to have, expect to have for a very long time, and they have one perspective on productivity and health and safety for their employees. There are other businesses that are not rooted in place that are just as happy to move and for a lower cost of labor rather than deal with productivity and benefits and a whole set of other issues. There are companies that have a lot of turnover, a less skilled workforce that are not going to invest. And it seems to me the approaches to them, to those different kinds of organizations, are quite different in terms of what you want to appeal to. That's in their self-interest and is also in the service of health. So perhaps you could comment on that.
What do I know about this? But I have an opinion. I slept at a Holiday Inn sometime in the last month. So the first thing that's stimulated by your comment, Ray, is the fact that when I was medical director at Health Partners, looking at the different industry groups in which the employers fell in terms of the kind of companies they were, drove the health care profiles, chronic disease distribution, the risk profiles, and so forth. So, I agree with you. There's no monolith. I mean, it's pretty apparent if you look at data from different companies that these companies are not a monolith. And if you think about their business models more than just a few minutes, a McDonald's corporation with teenagers, in every block in the country is going to be a lot different, than a company that's in one location, has a high concentration of employees, maybe has an office workforce. It's just going to be a lot different. So, I think we take a risk in over generalizing the approach to business as a whole. And we need to, at some point, get down into a level of detail, which would require more than an evening at the Holiday Inn, or my speculation.
Well, I mean, the comment I would make myself is that as we try to work in communities and build multi-stakeholder coalitions, I don't need y'all. I just need some to actually wake up and say, we've got to make a difference. And those who aren't going to be really invested in the community, so be it. I don't have an answer for those.
Yeah, I've been thinking a lot today and in recent weeks about one of my first mentors, John Eisenberg, some of you may remember, had written a paper about who will protect the commons, and it was aimed at physicians and talked about, if every physician operates in the patient's interest and nobody thinks about society's broader interests, we're never going to get anywhere in terms of controlling costs and improving care. And that was, I think, 30 years ago that he wrote that paper. And I'm thinking about how does that apply to the conversation we're having today, that if every business said, I'm only interested in thinking about my own workforce, and so I have high turnover, ultimately your high turnover is going to come work for me next, and mine is going to come work for you, and somebody has to take an interest in the commons. And I've been thinking about how do we convey that message to the business community that we have to have a shared responsibility here, because if everybody's only looking out for their own interests based on what does my population currently look like, we're going to continue spending more and more and getting less and less.
To that end, I hear a lot of talk about one size fits all, or behaviors and attitudes, which I look at as two different things, right? One size fits all is for the general public, and then attitudes and behaviors is each person. But I don't hear any talk about built environment change. And one of the slides, I believe, George, you pointed it out, it had only a 10% focus on environment change, but it seems like most of the companies are focusing on attitudes and behaviors, which we know don't really work. So I'm just wondering if there's any sort of coalition behavior or activity that's working, with multi-stakeholders to actually improve the built environment, so to make our waterways better, to put in greenways, establish things that are really going to affect lots of companies and lots of people all at one time.
Just to respond directly to that, I think in terms of, and I think this is an excellent question, I think in terms of what's happening today, you may be exactly right. I think the one reason that I put forward that diagram that I did in terms of what the individual firms' approach is to the determinants, before I got to talking about, the common business model, is that first you have to know what you can do, what assets you have as a firm, and how you can come to the party. So for many businesses, working on their own workforce and buying healthcare smart and driving down the healthcare is going to have huge impacts on the collective. But then the most challenging part is when you come down to things like the environment and building, the green spaces and the activity and working in terms of the distribution of food in communities and so forth. And that's where what business can do, a business can do, is join with others and be a good follower, not necessarily a leader. And what that means for business is that you have to let your ego at the door. You have to realize that you're not an expert, that there's a lot of other data and so forth. But because you're concerned about the larger health of your employees and community and the relationships of that, and you have something to gain, that you need to be humble in terms of participation and bring your. So the other part of that is that the coalitions that need to be put together have to address the imbalance that we currently have in the investment in those other social determinants, in my opinion. And that, of course, is a policy issue that we face collectively. So that's how I would answer it.
Just to clarify, at the individual business level, many businesses are addressing the built environment at the workplace. It's not necessarily translating to the broader built environment of the community. So a lot of our businesses have put in bike racks as an example. It doesn't necessarily mean you have safe paved bike lanes to get to the bike rack to get to work. And I think that will be the next step, but I think it's very encouraging that employers are recognizing at least The built environment needs to start for them at the workplace. I was joking before, wouldn't we all be more physically fit if the bathroom was always one floor above or below the meeting space? Because I've been up and down stairs more times today than I am in a typical day at work.
I think we have time for one more question.
I wanted to raise a question that is maybe a little bit afield from the business engagement, but also on Emma, who with the Pacific Business Group on Health, that I wanted to ask a question with respect to provider engagement as sort of the other side of the coin. And there's a raging debate at the National Quality Forum right now around risk adjustment for measurement. And in many ways, that often is a concern to consumers and purchasers because it sometimes ends up as a rationalization for differences in outcomes and the measurement of the population's health. And I'm wondering what your perspective is on that and how we could come together on a collective strategy for looking at population health that recognizes differences but doesn't allow for justification of those differences as performance metrics become part of the payment mechanisms and other published criteria.
Okay, so I have a perspective. So in thinking this through, what we lack in terms of quality measurement is clear rationale for the purpose for which we're measuring. And for some purposes, risk adjustment is important, particularly if it's comparison and payment of incentives for performance. In many other cases, risk adjustment adjusts away the key issues that we're trying to address in terms of addressing disparities and other issues in communities. And it actually may, if it's applied inappropriately, take away the pressure that ought to be on all institutions to figure out how to address these things. And so there's not like a right answer to that question, but it's a key issue. In Minneapolis-St. Paul, through the data collaborative we've had there, we've had a philosophy of not risk adjusting, actually, and trying to understand the differences. And then in other payment mechanisms that we participate in, we do risk adjustment. We have to be very, very clear about this. So one thing that National Quality Forum is currently discussing, and I participate in the National Quality Forum in terms of chairing the Measurement Application Partnership, is really trying to articulate more clearly the rationale. The other thing that doesn't help this argument is the mindless, simple push towards simplification and harmonization. Simplification and harmonization of measures so that we aren't duplicating effort and measuring things differently and thinking they're the same is really, really important, so don't get me wrong. But the mindless application of that principle so that we have to have either a risk adjustment or a non-risk adjusted measure, and we can't apply it in these different circumstances where it's important to look at the different information, in my view, is not a good development. So that's how I would respond to that.
I of course think outcomes have to be risk adjusted, particularly if you're going to link to payment or publish the data. But I think that, and I'm a quality measurement guy. That's what I've done in my career. We sell short today. We've swung the pendulum too far towards it's all about outcomes. I think process measures still have a place, particularly for a lot of the things we're talking about today. Like working with a large academic practice in Philadelphia, we saw that whether a person smoked, smoking history, and whether anything was done about that was not documented in the vast majority of charts. That's unacceptable, and that's a process measure that doesn't lend itself to risk adjustment. Whether weight is recorded in the chart, whether obesity is diagnosed, whether treatment is documented in the chart. These are all process measures that will help to drive population health, and we ought to be focusing on those while we continue to improve risk adjustment strategies.
We have one last question.
It's actually a statement, and it's just a response to what McLevine said. She said that awareness and behavior change programs don't work, and I'd really take issue with that. They're not enough. They're part of the solution. I think the environment, the policy is very important, but we've got lots of extremely successful behavior change programs. So just didn't want to leave that hanging out there. I embrace the larger idea that everything is needed.
Thank you. So please join me in thanking our panelists again.